Good afternoon, everyone. I'm going to present a rare case of mucoepidermoid carcinoma of the lacrimal gland. Mucoepidermoid carcinoma is extremely rare in the lacrimal gland and prone to local recurrence and distant metastasis. Histopathology and immunohistochemistry markers aid in the accurate diagnosis. A 50-year-old male presented to our clinic with history of prominence of the right eye since 3 months. On ophthalmic examination, the best corrected visual acuity was found to be 6 by 6 in both the eyes. Pupil was normal. Pupil was 3 mm, normally reacting to light in both the eyes. Hertel's exophthalmometry was carried out and was found to be 17 mm with inferior dystopia in the right eye. Left eye it was 12 mm. There was raised retrobulbar resistance in the right eye, and regional lymph nodes were negative. Magnetic resonance imaging (MRI) was performed and was found to show a very well circumscribed homogeneously enhancing mass in the superolateral orbit extraconally. So we carried on with right eye excisional biopsy under general anesthesia, and upper eyelid crease surgical approach was surgery was approached. Histopathologically, the patient, the slide showed a lot of squamous cells and mucin producing cells which are poorly differentiated, and a lot of mucin which is also seen on the slide. Immunohistochemistry found to be positive for cytokeratin S100 and P63. On follow-up, we had systemically evaluated the patient with PET-CT, which was negative for systemic metastasis, and patient was referred to higher center for external beam radiotherapy, and patient is currently on follow-up with 3-monthly MRI and annual PET-CT. This is the picture pre-operatively and post-operatively at 2 years follow-up. We can see that the dystopia has decreased and the proptosis also decreased. In discussion, we would like to say that mucoepidermoid carcinoma of the lacrimal gland is a rare entity, and it is more commonly seen in salivary glands. However, there are multiple histopathological grades, and the management depends upon the histopathological grade. Immunohistochemistry can aid in the diagnosis, and a longer follow-up is needed for prognosis and survival rate. As in our patient, we had only 2 years follow-up. This case is presented for its rarity. And these are the few other articles which also suggest that primary mucoepidermoid carcinoma can also occur in the lacrimal apparatus. And this was a 25 cases series which was published previously by in another journal. Thank you.
What was the size? What was the size of the mass?
Ma'am, it was 2 centimeters by 1.6 centimeters, ma'am.
So you were able to remove it with a Lacri incision alone?
Yes, ma'am. A superior Lacri incision was carried out, which was laterally extended, and the mass was removed in toto without rupturing the capsule, so that we don't cause any local recurrence.
In case of a lacrimal gland tumor, is it mandatory to remove the bone in all cases?
Sir, if the
for operation point of view, I'm asking surgery point of view.
So surgically, it is important that the mass is removed in toto, but if the radiologically and on table, if there is no bone which is involved, then it's not necessary to remove it, unless and until we are not rupturing the capsule, which can cause local recurrence in the patient.
That's a point actually.
Yes.
So if you are confident without rupturing you can remove the surgeon, then there is no need to remove the bone.
Yes, sir.
Earlier it was that issue in every case we should go for bony removal in lacrimal gland tumor. Now that we can avoid that one with the help of the microscope.
Yes.
We can see that. That's the reason is that earlier we are doing with the low microscope.
Okay, sir.
Okay.